Hey, Nelson. I'm just waiting for Louis to join. Oh, there we go. Hi, again.
Hello.
Okay, so right on time, maybe a minute early. We'll just make sure we're looking good. Our little pre-planning worked. Oh, hey, Nelson. Okay, so may as well get started. So just for anyone that doesn't know me, first of all, even though it's my Instagram, so you might have a little bit of an idea. I'm Frances. I'm a physiotherapist. I'm based in Brisbane. And I am chatting today with Louis, who is my friend these days, who's also a physio in Brisbane. So Louis graduated from UQ as I did, just a few years after I did. He works at Excel Physio in Hawthorn. He's CrossFit Level 1 coach, and he is, like me, particularly interested in evidence-based practice. So I met Louis, I guess it was last year.
Through the gram.
Yes, through the gram. So Louis reached out to me over Instagram and just kind of, brought up that he felt like we had similar ideas and whether we wanted to meet and chat. And Louis is actually one of the reasons I started doing my master's, because Louis could quote research off the top of his head, and I'm like, I want to be able to do that. So there we go. And what we're going to talk about today is scapular dyskinesis, after Louis telling me that he sort of was having a chat about it in his workplace the other day. So I wanted to ask you first, can we define what scapular dyskinesis is?
Yeah, thanks for having me on, Francis. It's I'm very honoured to be the first guest for your live video series. So, scapular dyskinesis, it's I guess a bit of a long-standing theory in the shoulder pain and rehab world as to being a source of shoulder symptoms. So it's sort of defined as like a change or deviation from the normal resting position or active position of the shoulder blade while moving. Okay. And this is proposed that it may be a source of shoulder pain by increasing load on the rotator cuff and the contents of the subacromial space while you move. And I mean, from a mechanistic perspective, it makes good sense, right? Like it's very intuitive. It's certainly a big issue for people who have dramas with like a neurological injury to their long thoracic nerve or accessory nerve. So that will cause some really funky movement of the shoulder blade off the chest wall. But it's also proposed to potentially be something that causes pain in just regular run-of-the-mill rotator cuff shoulder pain. I think there's a number of issues with this, though, despite the fact that it sort of makes good sense on a theoretical level. And it's like many things in musculoskeletal medicine. I think like we have these ideas that are really theoretical, and then we take them and run with it. But then when we actually do some research into it, it proves that it's not really correct or doesn't really bear out like we thought it would. Yeah. So if we think about the anatomy of the shoulder, right, you've got your scapula suspended in the thorax by 17 different muscles anchoring it to your mid-back, neck, ribs, and arm bone. There's quite a lot of moving parts there. Yeah. And I think to define abnormal, we first have to be able to say what is normal. And when you dive into the literature on that, it's very difficult to say what is a normal resting position of the scapula, what's normal in terms of movement. Yeah. We've seen that the resting position tends to vary based on your hand dominance. So whether you're left or right-handed, the shoulder blade may sit slightly differently. What kind of upper limb activity you do regularly and habitual positions you put the shoulder in. So baseball pitchers, as an example, the scapula on the dominant side has been shown to rest slightly more upwardly tilted and internally rotated, and also tilted forward a little bit more than their opposite side.
That's interesting, because my dominant hand, like, for sure does that. And I definitely attributed my shoulder pain a few years ago to that, and kind of went down the whole, like, trying to assess my own scapular movement thing. So that's an interesting point.
It is interesting. Yeah, absolutely. I think the other thing too, like we have this idea that there's like, I guess a general pattern of scap movement when we like raise our arm overhead, and that's to progressively upwardly rotate, to posteriorly tilt or tilt backwards, and either turn in or out a little bit. Yeah. There's also this notion of scapulohumeral rhythm, which is that for every 2 degrees of movement at the ball and socket, you'll have 1 degree of the shoulder blade turning up, because the socket part of the shoulder blade needs to face upward to help get our arm up to here. So that makes sense.
Uni. I never thought about it ever again since uni, but I can remember those lectures very well.
And it's a good thing that you haven't thought about it too much, because it's actually not really true. Like we see that the rate actually varies anywhere between like 6-to-1 and 2-to-1.
Okay,
The rhythm and how much movement there is varies again with hand dominance, with how fast you move, how tired you are, if you're in pain. And if you compare like a constrained task like lifting your arm to a more functional activity like throwing a ball or doing a snatch, you'll also see differences in how the same person's shoulder blade moves.
Yeah.
So, I mean, if you think about like having a physio look at how someone's shoulder blade moves when they lift their arm, or just how it sits at rest, that may not be overly relevant for somebody whose pain occurs while they throw a ball or while they press a dumbbell overhead. So I think it's very challenging to actually say what is normal scapular movement. And as we'll go over sort of soon, there's a lot of like, I guess, asymmetry and differences in how it sits and how it moves, even in people without shoulder pain.
Yeah. Okay, so I guess you've basically defined it as, well, dyskinesis is an abnormal movement of the scapula. That's how it's defined, and that's what I learned at uni. But I guess our question today is whether is that a real thing, and you're sort of indicating not necessarily. And I guess that leads me to my next question, which is, can we accurately assess, I suppose, scapular dyskinesis or scapular movement? And I ask that because I know that in like athlete screening tools and stuff, they might have it in there. I'm trying to remember if in my subjects at uni last year if we talked about it. Probably. It's one of those things that's always just thrown in as like a throwaway line, like, is there abnormal movement of the scapula? So yes, do you think we can accurately assess it in any way?
I think sorry, you go.
I was just going to say, and should we bother, and should we put it in screening tests for athletes?
I think it's worth looking at. Like, I think we should always observe how it moves. I think that visual assessment of just subtle differences in scapular movement has very poor inter-rata reliability. So what that means is if you and I both assess the same person's shoulder and watch how the shoulder blade was moving, we'd probably have very different ideas about how well it's moving or how much upward rotation there is or whatever. So it's certainly, the visual assessment of scapular movement has poor inter-rata reliability, but I guess the exception would be when you have cases of like long thoracic nerve palsy or neurological injury. It's very obvious that something very funky is going on. So it's always worth looking at, but I guess I don't think we can make a really good in-clinic assessment just relying on our eyes alone. In the research... Can
I just throw something in?
Yeah.
I'm going to throw something in. I noticed too with me that like once you know what side hurts, it's like your ability to assess it accurately is gone because you know it's hurting. So you're looking for those changes and, well, this is me anyway, but I'm sure other physios do it. Then you're kind of looking for something to blame. And so your ability to assess it, even yourself, I feel like it becomes quite hard once you know that what side is in pain, let alone someone else coming in and, anyway, yes,
absolutely. and I think that's interesting because we've got another paper that was done relatively recently, and what they did was they took a group of patients who either did or didn't have shoulder pain, and they had a group of therapists assess how their shoulder blades moved. And the experiment was, let's actually not tell one group of people who doesn't have shoulder pain and tell the others who does. And what they found was that therapists were more likely to label someone with dyskinesis if they knew they had shoulder pain beforehand.
Yeah.
Whereas the same people assessed by a therapist who didn't know that they had shoulder pain, they were less likely to pick up anything funky going on. So I guess it suggests that the way we're trained through uni and maybe through these courses that some people go on, like, tend to bias us towards finding this dysfunction even when it doesn't exist. It's kind of like pareidolia.
Definitely.
Like, for instance, you see Jesus in this piece of toast, and now all you can see is Jesus in the piece of toast. So I think sometimes we see what we want to see or what we think should be there versus what really is. So I think that's certainly a visual assessment. I don't know that there's a lot of good value in doing that outside of the gross neurological problems. scapular movement can be more accurately assessed in a laboratory setting where you have like 3D data from magnetic tracking systems and fancy stuff, but general day-to-day clinicians and coaches, you don't have a lot of chance unless something really funky is going on.
Yeah. Okay, so you're basically saying that for like in athlete screening scenarios where they do have access to that stuff, do you think it's worthwhile? I think you might have said last time we chatted that there was maybe some evidence that in like elite sport there was potentially some relevance.
Yeah, so they've done some prospective research on overhead athletes. So, following a group of people over time from baseline, looking at who had, like, nobody having shoulder pain to begin with, and assessing scapular dyskinesia, and then following them over a period of time. And they've done this in baseball, tennis, badminton, volleyball, handball. So for the first four, baseball, tennis, badminton and volleyball, there was actually no association between having a funky scapula at baseline and developing shoulder pain in the future.
Do you know, and I'm really sorry to just ask you this, just in case you don't know the answer, but do you know how they assess it? Like, was it at rest? Was it with movement?
Yep, so the two methods I've seen when I've read through the paper is either like this lab measure using that magnetic sort of technology to look at that. I've also seen it assessed using, not so much with movement, but certainly resting position. They use like a tape measure to look at where the angle sits relative to the thoracic spine. And I think you've probably seen this. And maybe when you raise your arm, then how far does it sit away again? But I think the better papers tend to use the pretty flash 3D modelling to do it.
And do you think are they mainly looking at like lack of upward rotation, or are they looking at it like, what's it called, winging, when it like sits off?
Yeah, both. They look at look at does it sort of internally rotate and the shoulder blades lift off the chest wall? Does it upwardly rotate as much as the other side? How much does it maybe tilt more forward or backwards? So, and they kind of
all of the things.
They'll look at everything, right? They tend to, because it has so many like degrees of freedom and obviously that many muscles anchoring it to the chest wall. It's got a lot of potential movement available to it. Yeah. So where there is some conflicting evidence is in high-level handball.
Okay.
So we had one study showing a small correlation, but another one sort of as like a replication study where there was no link. Right. So I mean, potentially at the upper level of human shoulder function, there may be an argument that something being a little bit off could be a risk factor. Yeah. But it's still a little bit ambiguous, and I wouldn't say worth investing significant time or resources in until we can actually prove that it is a problem for those people.
Yeah. Okay, and so that kind of covers whether we should screen for it in athletes, which, to be honest, is not the area I work in. So moving on to the area that's more familiar to me. So considering someone who is already in pain, do you think it is relevant how their scapula is moving?
I think it's certainly worth looking at and I guess asking them about, right? But I think, again, the evidence doesn't really support that notion either. And it sort of speaks to a lot of these things that we've kind of deemed to be dysfunctions in the body, I guess, that are based on theory. It works in theory, but not really in practice as such. So there was a systematic review in 2013 that actually concluded that no physical examination test of the scapula was found to be useful in differentially diagnosing pathologies of the shoulder. So it can't actually, like, looking at those things in a clinic can't really give you information about what's really going on with the shoulder itself. And then the other thing that they said, and I'll have to quote this word for word because it's a great sentence, scapular asymmetry in motional position is not an indicator of shoulder dysfunction and is not limited to those with shoulder pathology. So that kind of reiterates the point that some variation in asymmetry in how it sits and moves is actually really normal. Like, it's not just isolated to people with shoulder pain. I think where it may be relevant, and particularly when, like, it's not like a gross dyskinesis, but maybe it just feels funny to the person, or maybe it looks a little bit funny to you. Like, it's very hard to say, well, was that the cause, or is this just something that's developed after they got sore? So kind of like if you roll your ankle, you'll limp on it, right? Yeah. To take the pressure off. I think that it's reasonable to say that the muscles of the shoulder are going to start to behave a bit differently when you're already sore. So it's kind of like a limp. So nobody looks at someone who sprained their ankle and say, well, maybe if you weren't limping, you wouldn't have sprained it.
Yeah.
Like that's just bad reasoning. So and I think it's kind of similar.
That. Yeah, I love that idea, because I feel like that's how I've started to really think about so many things I see. The person comes in pain, because that's what we usually see as physios, and then they're moving in this slightly abnormal way on that side, and then yes, we blame that and go, oh, that must be why. But exactly what you're saying, it could be that they're moving like that because of the pain, and so if you try and address that, it's probably not going to get you anywhere. So yeah, I love that thought, and that to me, out of like everything to do with scapular dyskinesis, that's probably what speaks to me the most, in that how can I trust what I'm assessing was there before. And yeah, just something I guess I noticed too is that when someone's in pain, and I know I do this, they're looking for something different to the other side and attributing value, but they might have had that scapular pattern forever, and then now that it's sore, you know, they're blaming that, but they also suddenly added lots of load, but they're blaming the abnormal movement. So
yeah, absolutely. It's that whole thing around, like, when we're sore, we go looking for answers, we go and try and find meaning, and we can sometimes become a bit hypervigilant. We sort of overanalyze what's going on here, like what is the issue, and we can pick up on some stuff that may have been there all along, but now that we're sore, we're sort of connecting the dots, and they may be completely unrelated.
My understanding is that there is some research that shows that scapular stability exercises do actually improve outcomes for people with shoulder pain. And just to clarify, like, what do you think a scapular stability exercise would be like? I remember at uni, it was those weird lie on your stomach and do like lower traps. And then I feel like, do you think those ITY exercises, are they kind of scapular stability, or what do you think?
I think it depends on who you ask, honestly.
Right.
But the idea is that the scapula has to form a stable base for the glenohumeral joint to function on. Yeah. So if it's not set enough or not sort of absorbing enough force, then there's more load on the rotator cuff. But like I said before, the scapula, or the joint between the scapula and the rib cage, is it's quite a unique joint, in that the only bony attachment between the shoulder blade and the body is via the collarbone, and the rest of it is just supported in muscle. It's like Jared Powell says, it's suspended in a sling of muscle, right? So it's not a very stable arrangement, right? It's just sort of on your chest wall, anchored by muscle. So to call it stable, and if you look at how it moves when we go overhead, it has to move around and turn up and down. It's not set in place. So, I mean, when we talk about scapular stability exercises, often we are talking about contracting those muscles or setting it in a certain position to try and take stress off part of the shoulder. And I think these types of exercises have been proven to work for pain. But interestingly, that has nothing to do with changing the position of the scapula.
Yes.
So we've got a couple of RCTs now that show that you give a person a program and you watch them over a period of like 6 to 12 weeks, and people get better, and sometimes significantly better. But their scapular motion and timing of how the muscles work doesn't change. Yeah. Despite the fact that that's what's been emphasized. It's just exactly the same as it was at baseline. Probably one of my favorite ones was done by Philip Struth and colleagues in 2012, and it's one of the best described RCTs I've ever read. Like, really? I don't know if you
I have not read
papers,
and
they talk about, like, when you read an RCT often and they talk about exercise, they don't describe what they did very well.
Yeah, they do
like,
not.
Philip and these guys, they really went into a lot of detail about each intervention. And they talk you through every step and like every progression and regression and how they told people to avoid pain and all these things, right? And so they had two groups with shoulder pain and a possible dyskinesia, and one was assigned exercises with like a heavy emphasis on like where the scapula sits and working those muscles, and the other one was given more general exercises for the rotator cuff and a friction massage. And in this study, they found that the scapular exercises seemed to help more with pain, I should say, than the other one. However, it did not change the resting position of the scapula or how the scapula moved.
And I'm like curious now, did the rotator cuff exercise group have a lower total dose of exercise?
Yeah, I was about to comment on that. It seems as though they didn't do quite as much work, which does make me think that again is a variable that they maybe control very well.
Yeah.
But, I mean, it kind of shows that this stuff can work, right? It's not that we have to throw the baby out the bathwater. We can do exercises targeting the shoulder and the scapular muscles, I should say, but we don't have to go with the narrative of we're correcting your position, because we're not.
Yeah.
Like, that's just not, not true.
Yeah, and I guess it's like that's the whole can of worms with exercise as a whole, in that even saying, like, I know there's been lots of discussions about does it actually make you stronger and these types of things. And it's like those narratives, like we're correcting movement or we're making you stronger, which sounds so obvious. It's actually not happening. So exercise still works. And like, I love that idea. Like, I feel it's given me so much more freedom with how I prescribe stuff, because I'm like, it's doing, it's not correct, it might not be correcting, but it's loading the part that hurts, or it's getting you doing something that you thought you couldn't do before, or building capacity, like whatever it is.
Yeah,
but those things of it's fixing your position. And the reason I asked about the workload was just because it reminded me of, it's slightly different. It was rotator cuff tendinopathy, but there was a systematic review, I think last year, because I did it for one of my assignments, that was trying to look at whether like dose was relevant in rotator cuff tendinopathy, which is like in the ballpark of what we're talking about. And there wasn't that many studies, but the thought was that whether it was higher load, as in like weight, or higher volume, it didn't really matter as long as you were doing more. Like, the higher the workload, the better the effects, which I thought was really interesting too. It's just that idea of find something they can do and do heaps, just like make them do it often. And so I like that. And it's probably scapular stability exercises are quite low, not very provocative of pain, I reckon, people in pain. So there might be a good choice, but the way we phrase it might be different.
Yeah, definitely. And it's not that they're bad options, right? It can work for people. It's just not working for the reasons that we used to think it worked.
Yeah.
And that's fine, but I think we probably need to shift the emphasis towards just doing stuff that people can tolerate, that builds their ability to do the stuff they want to do, versus correcting dysfunctions.
Definitely. So I just have one more question, which is, if someone does come in with shoulder pain and their shoulder blade is moving abnormally, and like, say they might notice, because now that there's YouTube and Instagram, people are more clocked on to what might be going wrong, and they might say, oh, my scapula moves funny. I have scapular winging. Like, I've been trying to fix it, and it's, what would you do? Just a general...
Yeah, so I think
snapshot.
Yeah, I could go on for a while about that, but I think I'll try and keep it fairly brief. But I think probably the more common scenario is that, like, there might be some very slight asymmetry of scapular movement that I think is probably just normal variation. But often some people can feel like something really funky is going on there. They're like, I feel like it's not sitting right. It feels like something's wrong. It's moving wrong. And I think that, like, altered sensation of scapular movement may be like just a bit of a compensation to something going on with the rotator cuff. And that's actually supported by some of the research. I know there was one RCT that looked at like how the shoulder blades move when people do and don't have shoulder pain. And in that study, they actually saw that people with shoulder pain actually rotated their shoulder blades upward more than the people without. Which is interesting, right? Because that's almost counter to what people think. They think, well, no, it's not moving up enough. But in this group, it was like they were doing it more.
Interesting.
And perhaps that's that limp we're talking about, right? There's just that slight change in how stuff's working, because they're important to get your arm up overhead. Your cuff is overloaded, it's cranky, it's not really doing its job very well. And now that changes the behavior and how it feels.
That makes sense. Like a hitch. Like the thing where we're don't do that. Yeah.
Totally. So I think that, like, I tend to maybe, I'll obviously not dismiss the thought out of hand. I'll have a good look at it and I guess validate the way they're feeling, but also explain that, look, there's nothing too funky going on. But perhaps because the cuff's a bit overworked, a bit grumpy, that these muscles are having to work much harder to get you up overhead. Okay, and maybe by getting your rotator cuff doing a bit more and desensitizing it through rehab, we can actually get those muscles working a bit more like they normally would, or take a little bit of the load off and shift it elsewhere. Yeah. And then I'll always look at, like, assessing a person's rotator cuff strength or tolerance to pushing hard, or endurance and those things, and trying to give somebody something to focus on that. I tend to go with the Joe Gibson approach to that, to be honest, which she talks about, the the scapular muscles and the she talks about the scapular muscles and the rotator cuff muscles are like gin and tonic.
Okay.
They should never be separated.
Yeah, totally.
So I think I will focus on a bit of that, but I'm certainly not necessarily telling people that your shoulder blade's going to fall off your chest wall or anything like that. I think that's not really supported.
Yeah, and I guess like the idea that they don't work separately is obviously really logical as well, because as soon as you lift your arm, they're both going to work. Like, you can't isolate them. It's impossible. No, so if you're strengthening one, you're probably strengthening the other. And yeah, I was just going to say that the time when I saw the most kind of extreme example of scapular dyskinesis was when I was working in the UK. I've told you about this before. People had these really hyper, like very unstable shoulders, as in truly unstable, sort of slipping out of the socket just with little movement kind of level. And their scapulars would do this huge, you could see the inferior angle like winging big time off at the back. And you could just tell intuitively that's not the issue here. And Andrew Jaggi, who was this awesome physio I worked with over there, explained it really well, which was that, like, if your shoulder is going to slip off the socket, your body is going to do whatever it can to keep it on, and so your scapula is going to get under there and try to get under that bone and try to hold it in place. And so she kind of agreed that, like, the muscles that hold the rotator cuff, the muscles that hold the bone onto the socket is your rotator cuff muscles. So you really need to strengthen those to hold it in place, and then the scapular muscles are kind of secondary. So it's probably going with what you're saying, that rotator cuff is where it's at. And I suppose, I mean, rotator cuff exercises, again, like every exercise is a rotator cuff exercise. So the world is our oyster, really.
Yeah, totally. There's lots of options. Hey, it is just about finding what's going to work best and what a person responds best to. And that can be a bit of a process of trial and error.
Yes. Okay, well, I feel like we've covered everything I wanted to say, unless there's anything else you would like to add.
No, that's great. That's great.
So this was the best ever. Thank you so much. And I'm hoping that anyone watching, next time you see one of those fix your, and then it's like scapular winging or something, just remember this conversation and that it probably doesn't really matter, and just get strong, and that's it. Cool. All right. Well, I'll see you soon, and I will see everyone else doing another Instagram Live in a few weeks.
Sounds great. Thanks, Francis.
Okay. Bye.